All right, ready to go. All right. So, welcome everyone. I'm Jackie Burgess Bishop. I'm the CEO for the National Kidney Foundation of Illinois, and it is my privilege to welcome you to our virtual discussion for Black History Month on obesity and chronic kidney disease. We have an absolutely stellar panel lined up to discuss this very important topic. And we are so glad that you could join us. What I'd like to also do is take an opportunity to thank our sponsors. Our symposium, our discussion is presented by Blue Cross Blue Shield of Illinois and also sponsored by Fresenius Kidney Care and UI Health. So we appreciate their support in bringing you this robust panel discussion. When we look at the National Kidney Foundation of Illinois, we know that our mission is to improve the health and well-being of people at risk for or affected by kidney disease through prevention, education, and empowerment. And understanding that mission, we have for you today as our wonderful MC, Monica Fox. Monica is the Senior Director of Outreach and Government Relations for the National Kidney Foundation of Illinois. She is also a kidney transplant recipient with a passion, and I can definitely emphasize a passion for educating and empowering patients to take control of their kidney health. Monica is also a co-host of the Journey Continues podcast. So with that, Monica, it's my pleasure to turn our very active and robust and informative discussion over to you. And thank you.
Thank you, Jackie. And thank you for your leadership. We truly appreciate your leadership and guidance in this mission. So it is my honor to be the moderator for this panel discussion today. Very important panel discussion. I can attest to the importance of it from a personal standpoint. So first, I'll set a few ground rules. We're going to have Q&A at the end of the session. So if you want to use the Q&A button, you can click there and put your information, put your question in there. We'll definitely get to it before we end. And or you can use the chat. You can put information in the chat box that's right at the bottom. I have the privilege now to introduce a very active patient advocate who is also my dear friend, Alexis Connell. Alexis right now resides in Texas, but she is an Illinoisan to her heart and will always be here with us at NKFI Illinois. And I couldn't think of a better patient to share her story because she and I have shared the trials and tribulations of obesity, weight gain, uh, transplant medications, infections, all of that. We have shared all of that late nights, early mornings, and in the middle of the afternoon. So I couldn't think of a better person to come along and share her story with us so that when we hear from these experts, we can put a face to it. So, Alexis, let's hear your story.
All right. Good afternoon, everyone. My name is Alexis Connell. I am a transplant recipient. In 2009, I was what they call living your best life. I was working, I was modeling full time, working out. I thought I was eating right. I was trying to do all the right things. And on a routine physical exam, they found some protein in my urine. They said it could probably be nothing, but we should just check it out. So they tested me a couple times over about 3 months. And then once it continued to be there, they sent me to see a urologist. And once I saw the urologist, they did a cysto just to make sure everything was okay. They didn't find anything. They recommended that I see a nephrologist. And I have to admit that I didn't go because I was healthy, at least I thought. I had no symptoms. I was just living my life, doing what I thought was right. So I didn't go. And probably about 8 months later, I woke up with severe back pain, which landed me in the emergency room. They thought I had a back injury. I thought I had a back injury. I was lifting weights at the time, so I thought maybe I just hurt myself while I was working out. I went to follow up with my doctor, my primary care doctor, as I was instructed to, and he asked me, did I ever see the nephrologist, as he looked at my labs, and I told him no. So he made the appointment for me and had me go. And when I went, I had already lost probably 30%, 40% of my kidney function. So he referred me to a nephrologist. I went in, I had biopsy. It took them months actually to diagnose me. My doctor ended up sending me to Mayo Clinic. I was diagnosed with fibrillary glomerulonephritis, which is a pretty rare disease, and it was very aggressive. I did a round of chemotherapy, which did not help. And so my kidneys went down very quickly. In 2011, I crashed into dialysis, as most kidney patients do. I ended up in the hospital. They took me to the operating room the next day. I got a peritoneal dialysis catheter and I started dialysis, and I did dialysis just under a year. During that time, I was on the transplant list in Chicago already. And my nephrologist recommended that I double list or multi list, I think it's called, in Madison, Wisconsin. So I went there. I was able to get on their list in 2012, I believe it was. And that was in April of 2012 when they added me to their list. And I finally got that call in July of 2012, and I got my kidney transplant. Um, since then, I've struggled a little bit. You know, the medications, we take immunosuppression therapy. I also, part of my therapy is prednisone. So I'm on prednisone, which, for most people, it causes weight gain. I'm one of those people. It also can affect your joints and things like that. So I continue to try to work out. I continue to try to eat right. But I tend to have setbacks because we're immunosuppressed. We're more susceptible to illnesses. I have to say, since I've been here in Texas, I've been sick a lot more, I think, than I was back in Illinois. But when we get sick, we get really sick. It takes us out for a while. So it kind of interferes, with me trying to stay on top of my weight. So I would say I definitely walk a lot. If I can do nothing else, I definitely walk. My job requires me to do a lot of moving around. So I would say I probably get about 15,000 at least steps a day, which is a saving grace for me. I do meal prep, so I try to prep my own meals. I am a foodie. I do like to eat out, but I try to make healthier choices when I eat out. I try not to eat fast food. But it is definitely a challenge. I would say that most people think once you get your transplant, you're all good to go. And in a sense, you are, as far as your kidney and the kidney functioning, but we have to be so careful of so many other things. So it has definitely been a struggle. And as Monica said, we talk all the time, about the different things that we go through. I actually just had COVID again for the fourth time. It was very difficult. I end up being off work for quite a bit of time. So it is a struggle, but I have to say that it's a struggle that's worth it because, when I was sick before was a lot worse than what I go through now. And there's things that I can do to try to stay on top of myself. I listen to my body. I have a great relationship with my physicians, all of my physicians. We work as a team and they make sure that they stay on top of my health as well. So I go out now, I speak, I work a lot with the Kidney Foundation. I've been to DC as a patient advocate. I go out and I speak. I'm an author. The book that I wrote it to basically for transplant patients, but anyone can use it. It's a journal. It has a little bit of my story, some recipes, a way to journal to keep yourself healthy. So I try to give back because I have a second chance and I know that I have a lot to share. My story, I can encourage other people. So I spend my time now doing that. But it is definitely challenging. But I have a great circle around me. I have great physicians. I have great friends. I know a lot of people who have been where I am now. We all share a story. We share a sisterhood, a brotherhood, and we kind of all keep each other on track. So it has been a journey, but it is a journey that I wouldn't trade for anything in the world. So I really appreciate it. And I appreciate being here and being allowed to share my story. Stay on top of your health, get tested, talk to your doctors, know what your numbers are. Even if you have no problems with your kidneys now, you want to know where your numbers are now. So if something happens, you'll see it, because by the time you start showing symptoms, it's sometimes you're well into kidney disease. So stay on top of it, talk to your doctors, and just, try to stay as healthy and try to do the right things as much as you can. And there's a lot of resources out there. I'm a resource, the Kidney Foundation, they're amazing. They help me so much. So there's just so much information out there and so many ways that you can stay on top of it. So that's what I recommend. And thank you for allowing me to share my story.
Thank you for sharing your story. I am always so encouraged and motivated when I talk with you or when I hear you talk. So we appreciate you being with us today. And so we're going to have questions and answers at the end,
Okay.
but we're going to move on now to Dr. Kennedy.
Thank
So,
you.
Dr. April Kennedy is a dedicated physician specializing in nephrology with a strong commitment to patient care and community service. She's a proud graduate of Xavier University of Louisiana. She earned her medical degree from the University of Chicago, Pritzker School of Medicine, and then she completed her residency in internal medicine at the University of Illinois at Chicago, where she distinguished herself as the chief resident of ambulatory care services. Girl does not play, okay? So following residency, Dr. Kennedy stayed at UIC to pursue a fellowship in nephrology, and upon completion of her fellowship, she joined Associates in Nephrology. So as a board certified nephrologist, Dr. Kennedy is equipped to care for needs regarding diseases of the kidney, hypertension, and electrolyte imbalances. Educating patients on recognition and prevention of kidney disease is her passion. Through education, Dr. Kennedy strives to improve health equity and decrease negative health outcomes, especially in minority communities. And we know this well because she works very closely with us. There's nothing we call her about that she doesn't come and help us with. Dr. Kennedy lives with her husband and 2 kids and 2 dogs in Chicago. And in her free time, she enjoys cooking, shopping, traveling, and walks on the lake. So thank you, Dr. Kennedy. We look forward to hearing from you now.
Thank you, Monica. Thank you for the introduction. And thank you, Alexis, for your story. I have seen one patient with fibrillary glomerulopathy. So you mentioned that it is rare. Yes, that is indeed a rare condition. I'm going to start sharing my screen and get to my portion. Okay, I think I got everything up right. You guys let me know if there's any problems here. Okay, so we are going to get to know our kidneys. I am probably biased, but I think the kidneys are an amazing organ, or 2 amazing organs. Typically, a person has 2 kidneys. They're bean shaped. They're about the size of your fist, 10 to 11 centimeters, and they're located in the retroperitoneal space in your abdominal cavity. The ureters are the 2 tubes that connect the kidney to the bladder, and then the bladder connects the whole system to the outside. So that's where the urine passes out and out of your body. I got to make sure I can advance my slides. Okay. All right. So each of your 2 kidneys has millions of tiny filtering units called nephrons. These nephrons contain hundreds of miles of tubes and filters that process your blood as it passes through. So this is the way that your kidney removes waste and excess fluid from your body, processes it into urine, and then has it pass out into the bladder as urine. All right, so the kidneys are tiny, but they are very tough. So your kidneys filter about 40 gallons of blood every day. So that means your entire bloodstream filters through your kidney about every 2 minutes. I think that is quite amazing. Your kidney is working 24/7, cleaning your blood, getting rid of fluid, making sure that everything is in perfect balance to keep your body running properly. So I was mentioning, obviously, the kidneys remove waste. I like to put this list up here because later on, when we're talking about numbers that are important for patients to know, you'll see some of these. So some of the big things that the kidney handles is removing urea, creatinine, handling sodium, potassium, phosphorus. The kidney also helps metabolize drugs and medications, get them out of your body. And then, of course, other waste products. Another big job of the kidney is that they help to regulate your volume. So clearly your kidneys make urine, so they're removing excess fluid from your body in the form of urine. They also regulate your salt or sodium balance in your body, which is very, very closely coupled to fluid. I like to give the example of eating popcorn, right? So you go to the movie, you get your popcorn, and you have to get something to drink because that popcorn is going to make you extraordinarily thirsty. That's the salt in the popcorn, kind of turning on signals in your body that once you put salt in, water's got to be close behind. That will kind of bring me to how we get, how the kidneys help to regulate your blood pressure. So the kidneys help regulate your blood pressure by balancing the amount of fluid and salt in your body and also releasing a hormone called renin. So just to give an example, when we talk about balancing the fluids and the salt and pressure. So if in the spring, when we get to tend to our gardens and water our pretty flowers here in Chicago, we turn our hose on. If you turn your hose on just a trickle, you really don't get enough water to help your plants grow. But same opposite thing, if you turn that hose on super high, that water shoots out and it'll damage all of your flowers and whatever you're trying to grow. Blood pressure in the body is very, very similar. It really has to be at a perfect balance so that you're getting enough blood flow to all of your vital organs without damaging them. So think of your blood vessels as this hose, and we can add the salt analogy with it. Your blood pressure is essentially that force. When you put salt into your body, that makes that volume expand. That creates a higher force coming out of your blood vessels, which is the hose. And when we have too high a force, just like you can damage your flowers and your plants, too high a force causes direct damage to the organs in your body. That includes your kidney, your brain, your heart, all of them. So it's really, really important to keep your blood pressure under control, and your kidneys play an integral part. I do also want to say that we're talking about sodium, and African Americans have a tendency to be more salt sensitive than others. So what does that mean? That means that when we intake salt, it has more of a negative effect on our blood pressure than someone else who might take in salt. So it's very, very imperative that we watch how much salt we take in because we know it's directly affecting. I have had a few patients who, with really, really strict salt restriction, they've actually been able to control their blood pressure and have require less medications. So watching that salt intake is key. All right, so there is normal blood pressure. I can't tell you how many times I talk to people in my office and they say, oh yeah, my blood pressure is always that high. 150, 160, that's kind of where I hang out. No, no, no. There are normal blood pressures. And these are blood pressures that everyone should be trying to get into goal. We do not want anyone to have higher blood pressures. We know higher blood pressures means more disease. So this is how we classify blood pressure here. Normal blood pressure is a systolic, that's the number on top, less than 120, and a diastolic, that's the number on the bottom, less than 80. We have some elements of what we call pre-hypertension, where we start to pay very close attention when we see people's blood pressure move into these directions. So mildly elevated blood pressure, pre-hypertension, is when you are 120 to 129 in that systolic and less than 80 in that diastolic. Stage 1 hypertension, when you're 130 to 139 in the systolic, and ranging between 80 to 89 in the diastolic. And then stage 2, and this is definitely when we can say that someone carries a diagnosis of hypertension and we're absolutely going to start treating aggressively, is when your blood pressure on top, that systolic is at least 140 and that diastolic is at least 90. Okay, so I was mentioning ways that we can control our blood pressure. Of course, there are medications, but there's also lifestyle modifications that can be done that we know clinically have been proven to help blood pressure. We're talking about obesity a bit today, weight reduction, maintaining a normal body weight, which is a BMI ranging 18.5 to 24.9, has been shown to reduce the systolic blood pressure by about 5 to 20 millimeters of mercury. We can also use abdominal waist measurement to, evaluate your obesity or evaluate whether or not you are obese as opposed to BMI. That's another measure that your clinician might use, just so that you know. There's eating recommendations that we know, clinically proven to help lower blood pressure. The DASH eating plan is one of the main ones. That is dietary approach to solving hypertension, not Mrs. Dash. Patients always ask me that. It actually stands for dietary approach to solving hypertension. So this is an eating plan where you are adopting a diet rich in fruits, vegetables, low-fat dairy products, and reducing your saturated and total fat. And what we have found that doing something like that alone can lower your blood pressure by 8 to 14 millimeters of mercury. Sodium restriction, I hope I gave a really good analogy for that so you understand how that works. Reducing that sodium to about 2.4 grams a day reduces blood pressure by about 2 to 8 millimeters of mercury, excuse me. Aerobic physical activity, so exercise, which of course is going to help you maintain a healthy weight. Regular aerobic physical activity, the recommendations, I believe, are still 30 minutes a day for most people, most days of the week, if not every day. And that can help reduce your blood pressure by about 4 to 9 millimeters of mercury. And then moderate consumption of alcohol. So men limiting their intake to less than or equal to 2 drinks per day, and women or lighter persons limiting to less than or equal to 1 drink per day can make sure that your blood pressure will go down by about 2 to 4 millimeters of mercury. And at the bottom, there's a definition of what a drink is. So 1 drink is about a half ounce or 15 milliliters of hard alcohol. So 12 ounces of beer, 5 ounces of wine, or 1.5 ounce of 80 proof or hard whiskey is equal to your drink. All right, so in addition to the things that I had mentioned a bit earlier, kidneys also help keep your body in pH balance, making sure that your blood is not too acidic. They help keep your bones healthy through some hormonal mechanisms, regulating calcium and phosphorus and your parathyroid glands, all of which play a part in keeping your bones healthy. And then they make a hormone that helps you make red blood cells. So there's a hormone that directly stimulates your bone marrow that your kidneys make. And this is why a lot of patients that have kidney disease have anemia, because they aren't able to make enough of that hormone. All right, so what is kidney disease? I mean, simply put, kidney disease is when your kidneys are no longer functioning properly. It's a serious disease, and it can lead to kidney failure. It can lead to heart and blood vessel problems, and of course, it can lead to death. The good thing is that kidney disease can be prevented, and the earlier we detect it, that is key in making sure that we prevent its progression. All right, so not all kidney disease is created equal. There are stages of chronic kidney disease. This chart goes through how we stage. So there's 5 stages. Number 1 being the least, and number 5 being the most. So number 1 is slight kidney damage. That's when your GFR, and I'm going to go through that on the next slide, but that's kidney function percent. That's something that's calculated in your blood labs. So when your GFR is more than 90%, that's considered stage 1 chronic kidney disease. At stage 2, when your kidney function percent or GFR is ranging between 60 to 89%, mild decreased kidney function, stage 2 chronic kidney disease. Stage 3 has been broken down into 2 separates, 3A and 3B, with 3A being the higher functioning. So still both are a moderate decrease in the kidney function with or without other evidence of damage. 3A is kidney function percent of 45 to 59, and 3B is kidney function percent of 30 to 44. Then we move on to stage 4, where we are defining this as some severe decrease in the kidney function, and that is a kidney function percent or GFR that ranges between 15 to 29%. And then stage 5, which we consider kidney failure or end-stage kidney disease, is when you are less than 15%. And this is when we would institute dialysis, of course, when we start thinking very seriously about transplantation. All right, so as mentioned, I was going to talk a little bit about that eGFR. So that estimated glomerular filtration rate, or eGFR, is a calculation that measures your level of kidney function, and as I showed, determines what stage you're at. It's a lab calculation. Again, it's going to show up on your lab forms, and you should see it. Historically, there were trials that had shown that persons who self-identified as Black or African American had higher creatinine levels. And so for decades, there was this thought that Blacks would have higher creatinine levels, but that wouldn't mean that their kidney function was any worse. As you could imagine, if that is not the case, which it has been found that it is not, that was really making it more difficult and putting African Americans at a disadvantage for having their kidney disease recognized and treated. So in about 2021, the National Kidney Foundation and the ASN Task Force recommended adopting a race-free approach to diagnosing kidney disease. And this is a very important step for healthcare equity. When you see your labs, most labs have taken out the race-based eGFR, but if you see your labs and it says Black or African American GFR, and then there's one that just says GFR, you always want to look to the one that just says GFR. We are now ignoring the one that says Black or African American, regardless of your race. All right, are you at risk? Unfortunately, most of us in the United States are at risk for chronic kidney disease. Diabetes, if you have diabetes, that is the most common cause of kidney disease that will put you at risk. Elevated blood pressure, the second most common cause, obviously puts you at risk. Smoking can cause some significant cardiovascular problems that will put you at risk for developing chronic kidney disease. Obesity, another very, very big risk factor. As you could imagine, obesity is also a very big risk factor for developing diabetes and developing high blood pressure. So it makes complete sense that if you are obese, that alone is going to put you at increased risk for developing chronic kidney disease. If you have a family history of kidney disease, diabetes, or high blood pressure, you are at increased risk. Certain ethnicities, African Americans, Native Americans, Asian Americans, Latinx, at increased risk. You all might be familiar with the statistic, African Americans are 4 times as likely to suffer from kidney disease than white counterparts. And then if you are age greater than 60, that is going to put you at increased risk for chronic kidney disease. Okay, a little bit more about obesity. As I had mentioned, it puts you at risk for diabetes, increased blood pressure. Excess body fat causes more pressure, hypertension, and it actually puts a strain on the glomeruli, those functioning units of the kidney, and makes them work too hard. And in that process of working too hard, that can cause them scarring and damage. So that's one of the ways that obesity alone can affect your kidney. Hormonal changes, there's hormones that fat cells produce called leptin and adiponectin that can negatively impact your body overall and hasten chronic kidney disease. Excess adipose tissue or excess fat promotes inflammation, and this inflammation can affect the kidney and lead to fibrosis, which is pretty much just kind of, it renders the kidney functioning units neutral. They are no longer able to function because they're fibrosed. Renal tubular dysfunction can happen in obesity. I had mentioned that you have miles and miles of tubes that are helping with filtering out all of the good and the bad things in your body. Obesity itself can cause those to dysfunction. And then lipotoxicity. So fat cells themselves and fat can accumulate in the kidney and cause direct damage that impairs function. And in fact, we can biopsy obese patients and see the negative effects that the fat cells can have on the kidney. All right, so if you are somebody who finds yourselves in any of the several categories that I mentioned that puts you at risk for chronic kidney disease, what can you do? As I had mentioned, chronic kidney disease is preventable and it is treatable if we're able to identify it early enough. So it's very important that you act now. Take responsibility for your health, advocate for yourself. Partner with your provider. Make sure you're getting all of your questions answered. Make sure you kind of know what questions to ask. Make sure you have a healthcare provider that you trust and you feel like is working in your best interest. Because a lot of times when you don't have that trust with your healthcare provider, it just makes it very difficult for things to get done. So it's important to do that. And I also like to remind patients that if ever you are in a situation where you don't feel that the healthcare provider you have is the one for you, it is your right to seek a new healthcare provider. And that can be done. So don't be afraid to advocate yourself and do that if you think you need that. Know your numbers. So there's important blood tests and urine tests that you should have checked on an annual basis, possibly more than annual, depending on your overall health. And it's important that you know where you are. Are you normal? Do you have abnormalities? So you can understand your risk. So some numbers that it's important to know are, number one, the albumin to creatinine ratio. So that's a urine test. And it's a urine test that tells us if there's protein in the urine. I learned in medical school that protein is the building blocks of everything, every cell in our body. And protein, your body wants to keep that in. It needs that to repair. When we see that the kidney is letting protein out into the urine, we know that that kidney is damaged because that kidney should not want to let protein out. Protein's the good stuff. Your GFR, that kidney function percent that I talked about, another very easy thing to check. Get your blood test and know that number. Your blood pressure, make sure it is under control. Under control is 120/80 or better. There's no other blood pressures that are under control. There might be some certain circumstances, certain illnesses that somebody might have that might allow a little bit more, a little bit less blood pressure, but you want to make sure that your blood pressure is at the goal that it needs to be. Your hemoglobin A1C. If you have diabetes, you know that's the number that we look at to make sure that your diabetes is well controlled. Know what that is. Less than 7 is what the American Diabetic Association likes. Me as a kidney doctor, we want that to be as low as possible. We want to get it down to 6 if we can, because we want to make your kidney think that there is no diabetic environment. And then your cholesterol level. As you could imagine, that has an impact on your blood vessels. All right, protect your kidneys. This is a bit duplicative, but I never think I can say it too much. Make sure your diabetes is under control. Make sure your blood pressure is under control. Make sure you're living as healthy a lifestyle as you can, watching your diet, watching the salt and the fat, exercising, maintaining that healthy weight, avoiding smoking. There are some medicines that are widely used that can cause problems with the kidney as well. And I always like to, make patients aware. So the nonsteroidal anti-inflammatory medications, these are things like Advil, Aleve, ibuprofen, Motrin, naproxen, great medicines, great for pain relievers, just not so great for people if you have kidney problems. Those medicines itself, when they've been used at higher doses or for too long of periods, can absolutely damage your kidney. So if you are known to have chronic kidney disease, it's something that you want to be mindful of and make sure you're taking over-the-counter medicines that are safe for you. Always ask your doctor before you take any herbal supplements or herbal preparations, because those too historically can cause problems in patients with chronic kidney disease. I always like to reference noni juice, which caused high potassium levels, and high potassium levels can stop the heart. So kidney patients were taking noni juice and getting high potassium levels, and that was quite dangerous. We know now kidney patients should not take that. So always ask your doctor before you take any herbal supplement or preparation. I know we have a dietitian who's going to speak, so I am not going to talk too much about nutrition. What I will talk about is the importance of plant-based eating. So a lot of the literature is pointing towards plant-based diet, having the ability to slow down the progression of chronic kidney disease. So if you're somebody who finds yourself suffering from chronic kidney disease, look into plant-based eating, talk with your dietitian, find out if this is something that is good for you, and then try to implement it to the best of your ability. Treatment options. So I mentioned that chronic kidney disease can be treated. As of late, there are some new medications that I'm sure if you watch TV, you've seen. The SGLT2 inhibitors are medications that have been touted, and we are showing that they are able to treat chronic kidney disease. They're slowing down the progression, and long-term goal, what we're hoping to see is that we will have less people on dialysis. They also offer benefits to your heart that have proven to be quite fruitful. So look into those medications, see if you're a candidate to take one of those medications if you do have chronic kidney disease. ACE inhibitors or angiotensin receptor blockers. These are like enalapril, losartan. They end in artan and ill. These medicines help control blood pressure, and they also help control that protein. Remember, I mentioned how we know kidneys aren't working right when they're letting that protein out into the urine. These medicines help to do that. If you're someone who is advanced to stage 4, stage 5, then we need to start considering plans for dialysis. Again, we typically start that if your kidney function is below 15%, even less, getting around 10%. We try to keep people off dialysis as long as we can. Sometimes we can't because of symptoms. And then kidney transplant. I know we've got an amazing transplant surgeon who's going to talk. All I will say is that you can be listed once your kidney function gets to around 20%. You don't have to wait till you're on dialysis to get on the kidney transplant list. All right, so I believe, yep, this is my last slide. I just want to remind everybody to know your numbers: blood pressure, A1C, cholesterol, protein in the urine, the GFR, kidney function percent. Those are all things that you should know like the back of your hand. Know your treatment options. Know if you're on the best medications and the appropriate medications. Talk with your provider. Make good decisions. Eat the best and healthiest diet you can. Avoid processed foods. Exercise. Make sure you're having those beneficial habits. And then follow up with your physician and your provider. Keep those lines of communication open and make sure you understand what is going on with your body. And that concludes my talk.
Thank you so much, Dr. Kennedy. I just love how you make it so plain. You make it clear and understandable and give good guidance about what to do going forward. So thank you so much for an awesome talk.
Thank you.
All right, now it is my honor to introduce Dr. Ashley Swa. She's board certified in surgery and highly skilled in transplant, with kidney and liver being her focus. With a wealth of experience and expertise in transplantation, Dr. Swa is committed to providing the highest quality care and ensuring the best possible outcomes for her patients. She ensures she stays up to date with the latest advancements in transplant surgery techniques and technologies and is passionate about improving the lives of those in need of a life-saving transplant. In addition to performing transplants, Dr. Swa is an advocate for her patients. She's dedicated to making access to transplant surgery equitable for all, including pushing for equity in gender and racial disparities in transplant. Dr. Swa also educates her patients on surgery as well as post-transplant care, so they are fully informed throughout the process. Along with her devotion to clinical practice, Dr. Swa has made advancing medical education and mentoring medical students, residents, and fellows an important part of her career. And I must say that I'm a fangirl. She is one of 2 of only about 15 female transplant surgeons, Black female transplant surgeons in the country. And we are delighted and happy to have her here at the University of Chicago. So we look forward to hearing from you now, Dr. Swa.
Thank you so very much for the introduction. I'm very excited to be here. I also wanted to thank Alexis for sharing her story, and I loved Dr. Kennedy's slides as well. I think the presentation I have coincides very nicely with hers. So I'm going to just make sure my slides are showing. Can you guys see them okay? Okay.
Yes.
Yes.
Perfect. So today I'm going to be talking about how obesity and chronic kidney disease impact the transplant surgery itself. So how does obesity and chronic kidney disease impact the evaluation process of becoming a transplant patient, and how does it impact the operation itself that we do? And so before I start, I have a disclosure in that I personally know what it's like to be obese and to be told that you need to lose weight and to struggle with weight loss. And I understand firsthand that it is difficult and challenging to do. And I share a lot with my patients when they come to the clinic, because I want our patients to know that we empathize with you and that we're not asking you to do something that we don't, many of us understand what goes into it. So I used to be 250 pounds and I gained a lot of weight during puberty. And it's not because my parents didn't take good care of me. Actually, they cooked dinner almost every night and we ate as a family. But it was once I had lunch money to choose what I wanted to eat at school, I chose very poorly. And I had a pediatrician who would tell me, Ashley, you're going to develop diabetes, or you're not going to be able to live your life to the full if you're overweight. And finally, when I decided I wanted to make a change, I stopped eating terrible food. I had poor nutrition, but I started eating more balanced. I started exercising, and the weight really just fell off. I mean, in the beginning, all I could do was 5 minutes on the Stairmaster, but I kept pushing each day. And as I noticed that I was feeling better, and even building confidence with the things that I could do with my body, it became something that is now my lifestyle. And we'll talk more about that later. But the other thing about my history is I also only have one kidney. And I wish it was because I donated it, but I found out in medical school, actually, that I only had one kidney. And so thankfully, my kidney function is normal, but because I only have one kidney, I'm very sensitive to a lot of the things that Dr. Kennedy shared about protecting my one kidney to make sure that I don't develop chronic kidney disease. So I just want all of those who are watching and learning to know that I have personal experience with obesity and kidney disease. And then I have clinical experience as a surgeon, because I'm putting my hands literally in people's bodies every day and seeing what's on the inside. So obesity for me is not just a number that we're telling you you need to reach. It's really seeing the impact of carrying extra weight on your body, seeing what it does to your organs, seeing how it changes the aspects of your operation. And so I have a very unique experience as I'm sharing with you today about how obesity and chronic kidney disease impacts the transplant operation. So today I really wanted to touch on the evaluation, kidney transplant process, as well as the surgery that we do and some of the potential complications. I wanted to start off with a quiz, and actually Dr. Kennedy gave you all a little hint in her talk, but I wanted to take a moment just to ask everyone who is evaluated for transplant, or who should be evaluated for transplant. And since you got a little hint from Dr. Kennedy, I'll give you just a few seconds before giving you the answer. There's more than one correct answer as well. But it's patients who have kidney failure who are on dialysis, or patients with kidney function that's less than 20% who are not on dialysis. And this is just what Dr. Kennedy just mentioned. Not everyone who has kidney disease is a candidate for transplantation, and that's because the operation has risks, and not just the operation, but the anti-rejection medications that we give that Alexis shared about at the beginning, those have risks as well. So although we want to transplant everybody, we really have to be meticulous about the different risks and make sure that we're being safe in who we list and who we transplant. So the goals of the evaluation are to assess patients or candidates who are coming to the clinic, assess their risk for developing an infection, for developing a cancer, and to also assess their risk for surgical and cardiovascular complications. And as was just shared, when you have chronic kidney disease, you're at increased risk for a lot of things that you may not have been at risk for if you had normal kidney function. So we do a very detailed evaluation to make sure we're being safe and not putting you at increased risk by taking you to the operating room. We also want to make sure that you're going to be able to tolerate the anti-rejection medications that are a part of getting a transplant to keep that new kidney happy. And we also want to make sure that you're going to be able to adhere to the recommended medical care plan. And so, just as I mentioned, I'm always asking myself, do the risks of surgery and needing to take anti-rejection medications, do they outweigh the benefits of being off of dialysis for each patient that I see, looking at them as an individual? As far as the surgical evaluation, when you're coming to see me as the surgeon, we're reviewing your heart and vascular exams because we know that kidney disease, chronic kidney disease, can have increased impact on your heart and your blood vessels. We're also looking at your blood work and looking at different imaging studies, and we'll go over some of those in a moment. We're looking at your functional status. Are you able to do all the things that you want to do currently? Are you moving around? Are you independent at home? Because I'm not just thinking about the operation itself. I'm thinking about your recovery. I'm envisioning you after transplant and wanting to make sure that you can thrive and do all the things that you couldn't do before transplant. I want you to hopefully leave me better than you came when you saw me initially. And then we're also going to make sure we do our cancer screening, and that's age dependent, but the anti-rejection medications, they not only increase your risk of infection, but they can increase your risk of cancer. And that's because the same cells that the body would use to attack a new kidney are the same cells that your body uses to attack an infection and the same cells that your body uses to attack a cancer. So we make sure before surgery that you don't have any active cancers. And if you have a history of cancer, then we want to make sure everything is under control and that it's safe for us to proceed with the transplant process. As I mentioned, and I'll say it a couple more times throughout this talk, your recovery is just as important as the operation that I do. So we're thinking ahead, not just about the OR day, but years ahead. We transplant you so you can live life to the full. So we're always thinking about your recovery as well. So what are some factors that increase surgical complications? Well, your age, and that's just because as you age, your body has more wear and tear. There are more potential for different disease processes to happen. And especially when you have chronic kidney disease, there's just more time for things to develop. Your weight, and we're going to talk a lot about weight today. Calcifications of the blood vessels can increase surgical complications. And we'll talk about this in greater detail in a moment as well. But calcifications represent vascular disease or atherosclerosis when the blood vessels are damaged. And then blood thinning medications, which many of our patients at the University of Chicago are on. And these are medications like aspirin, Eliquis, Plavix, Xarelto. While they do increase risk of bleeding, we do operate on those medications, but we just counsel our patients a little bit differently about the risks of bleeding when you're on those medications. So specifically, when we're thinking about distribution of body weight, the BMI is something that comes up a lot in the clinic. So this is your body mass index. And essentially, this is a calculated measure of your weight relative to your height. And so I have some pictures over here on the right. And what I'm showing is that when you carry a lot of your weight in your belly, this is not ideal. And many of you may be familiar with this already, but there are more risks to your health when you carry most of your weight in your belly versus when you carry more of your weight in your bottom or your hips. And so these two patients could have a similar BMI, but their distribution of body weight is different. And so when you come to see me in the clinic, I'm not just going to, look in the chart at your numbers. I want to look at you and examine you, and also look at your imaging to help me make a decision about your risks related to the operation that we are trying to perform with the transplant. So we typically will order a CT scan without contrast. And as the surgeon, we use that study to look at many things inside of your body that we can't tell by just looking at you with our own eyes. So a CT scan is designed to take pictures in multiple different directions, but you lay flat. And when I'm going to show you some pictures, they're of different views, but you lay flat in the scanner and there are different pictures that are taken of your belly. And for the pictures I'm going to show you in a moment, it's almost like you're a loaf of bread and your head is pointing away and your feet are pointing towards. And the CT scanner is able to cut slices through your body so that we can look at tiny pieces of you and be able to look at your organs and your blood vessels and make some decisions about risk and things. So what I have here on screen left is a normal image of a CT scan. And this is just like that loaf of bread that I just talked about. So here, what I'm showing you with my arrow is that there are, this is essentially a normal amount of skin fat. And then there's a fairly normal amount of organ or visceral fat on this cut for this patient. The two images I'm going to show you on the right, these are abnormal. For both of these patients, while they're two different patients, they have a similar waist circumference, and they also have a similar BMI when they come to the clinic. However, they have different distribution of their abdominal fat. So this patient on the top with this arrow, what I'm showing you is they have a predominance of subcutaneous or skin fat. This layer is a lot thicker than this layer here. And you see how tiny they look on the inside compared to all of this fat on the outside. So this is not ideal. And the second patient below, they have a smaller amount of skin fat, but they have a predominance of visceral or organ fat. So the space in between and surrounding their organs has a lot of fat in it, which is also not healthy. So, of course, patients ask, well, Dr. Swat, how can I lose weight? So there are many ways to lose weight, and you've heard a lot of them already today. But the traditional ways we tend to recommend are your diet, exercising, being active, really learning what's in your foods. Like Dr. Kennedy shared, understanding how many calories you're taking in versus how many calories you're expending through your activity throughout the day. And then sometimes accountability or support groups are very helpful. You can do things with friends, and some people are more successful when they're doing things with a buddy. You might say, well, how else can I lose weight? Because those forms are not working for me. So the GLP-1 medications or glucagon-like peptide-1 receptor agonists are becoming very commonly used in today's world. And, you might hear celebrities are taking them. And of course, a lot of patients are taking them now. And these are medications that work by mimicking GLP-1, which is a hormone that reduces hunger and helps you feel fuller faster and longer after a meal. Typically, patients will have greater and more sustainable weight loss than just with healthy eating and exercise alone. They were initially developed for type 2 diabetes to help control that. And we found that you can have weight loss benefit and low risk of harm. And so we're using them in carefully selected obese patients who either have or do not have diabetes in order to lose weight. These are dose-dependent medications, which means based on how much you weigh or what your kidney function is or what your desired weight loss is, the medications are titrated and adjusted adjusted over time. They do have side effects. Most of them are GI in nature. And so it's very important that you have a provider or a care team who understands how these medications work and who can monitor you so that you can be successful but safe. And so I'm really proud to share that at the University of Chicago, we actually have a program called Act Now, which is very fitting for Dr. Kennedy's charge that she gave everyone earlier. But the Act Now program stands for Access to Transplant Through Novel Approaches to Weight Loss. And it's a program that we have where patients who have living donors or who are close to transplant but overweight or obese can be helped to lose weight through coaching and personalized medication-assisted treatment plans. And so with weight loss, patients who were not eligible for transplant can become eligible for transplant and also reduce their risks of complications after the surgery, which is excellent. And our incredible Act Now transplant team includes our transplant nurses, our transplant pharmacists, and our transplant dietitians, and they are experts, and you will hear from one shortly. And this is just a picture with our phenomenal team members, as well as one of our patients who I had the honor of transplanting. She is our first patient to complete this program. She's a year out from surgery and doing very, very well. Few more slides. For some patients who still are not able to lose weight with medications, lifestyle modifications, and weight loss programs, weight loss surgery or bariatric surgery may be something that needs to happen. Keeping in mind, not everyone who needs something more is a candidate for surgery because these operations have risks. And if you have chronic kidney disease, we had talked already, you may have more risks for heart disease, vascular disease, etc. And we want to be safe. But for some patients, bariatric surgery is something that is needed. And I just wanted to briefly talk about the two most common weight loss surgeries that are performed. A Roux-en-Y gastric bypass is when we create a small stomach pouch and we redirect the intestines. And so because of the small pouch and the redirection of the intestine, this results in restriction of what you can eat and also restriction in what's absorbed. So that results in weight loss. And on average, patients can lose 70 to 85% of their excess body weight with this operation. The most common weight loss operation that's performed in the United States is a sleeve gastrectomy, and this is when a majority of the stomach is actually removed. This is only a restrictive operation, but because of how much of the stomach is removed, there's a decrease in the hormones that cause hunger. This can be converted to a Roux-en-Y gastric bypass at a later date if that's something that's necessary. But on average, these patients lose about 60 to 70% of their excess body weight. And then calcifications are also something that we see on the CT scan that's performed. Causes of calcification, age. As I mentioned earlier, as you age, more things are able to build up inside of the vessels. Dialysis, long-term dialysis can result in more calcifications, and that has to do with calcium and phosphorus and different things that are more likely to build up and be in the blood when you're on dialysis. And then smoking definitely causes increase in vascular disease. So this is a picture of the aorta here and branches of the aorta, and the internal and external iliac arteries are here. We actually sew the kidney to the iliac arteries. And so these are pictures, this white stuff around these arteries is calcification on both of these pictures here. And I'll talk in just a moment when we talk about the surgery, why calcifications can be risky when you're having a transplant operation. Before I do that, I just wanted to mention many patients are told because they have calcifications that they're not a candidate for transplant, but I would encourage you to always seek a second opinion. I'm not saying that we work magic as surgeons, but often there are ways to still have a successful transplant and do a good job in the operating room, even if you have calcification. So always feel confident asking for a second opinion. Now, as far as the operation is concerned, the surgery is typically 3 to 4 hours in duration. The steps include connecting those blood vessels of the new kidney to your blood vessels in the pelvis here, and then we connect the ureter to your bladder so that the new kidney makes urine through your bladder. The incision here is difficult when there's a lot of body fat, whether it's in the skin or around the organs, which is what I showed you on the CT scan there. So if you have more body fat, you're at more risk for wound infections and fluid collections building up, and the operation is just a lot more challenging. So this is one of the biggest reasons, aside from all the other reasons Dr. Kennedy mentioned, that we encourage patients to lose weight before going to the operating room for transplant. The calcifications that can develop on the arteries pose risks with the blood vessels. So there can be injuries to the blood vessels, and the kidney may not receive as good of blood flow if you have a lot of calcifications as well. So in conclusion, we want to transplant patients so that they can live life to the full, absolutely. But we recognize that surgery has risks and we want to be careful. So part of what we do in the evaluation process is trying to make sure that you can get ready for transplant so that your recovery is optimized. And so that operation is a lot more meaningful, and that kidney can last you a long time, and you can do all the things that you couldn't do before transplant. So thank you again for inviting me today. I'll answer questions later, but I wanted to let everyone know I'm actually running the marathon this year for the National Kidney Foundation of Illinois, and I hope to see you there. Thank you so much.
Thank you, Dr. Swan. That's so exciting that you're running the marathon for Team Kidney.
Yes.
We'll be out there cheering you on.
Thank you.
Awesome. Thank you so much. That was an absolutely phenomenal talk, just phenomenal. Thank you so much for sharing. And now I have the honor of introducing our final speaker of the afternoon, Tisa Ross. Tisa Ross is a registered dietitian specializing in transplant nutrition and dedicated to providing comprehensive nutritional care for transplant patients. Tisa performs detailed nutritional assessments, develops personalized meal plans, and designs specialized nutrition protocol in collaboration with the medical team to support patients through all stages of transplantation. Additionally, Tisa leads quality improvement initiatives and establishes clear nutritional guidelines to educate and support both patients and their families. Passionate about improving patient outcomes, Tisa is committed to delivering evidence-based nutrition strategies that promote long-term health and recovery. And Tisa is also a valued volunteer with National Kidney Foundation of Illinois. So we look forward to hearing from you, Tisa. Thank you.
Hi, well, thanks for having me. It's my pleasure to be a part of this dynamic panel, and I have thoroughly enjoyed everyone's presentation and slides. So let me share my screen. It says I can't share it. Let's see.
Try again now.
Okay.
I think maybe Dr. Swaz's slides were still up.
Oh, okay, great. Okay, great. Okay, can everyone see okay? All right, great.
Yes.
Perfect. Let me just minimize this here. Okay. So today we're going to talk about obesity and chronic kidney disease from the perspective of nutrition. So we will discuss today the classification of obesity, which we've already talked about before in the other presentations. What is a healthy plate? The renal dietary guidelines, renal diet and diabetes, why is weight important, and then managing obesity with CKD. So as we have heard in the other presentations, BMI is used as a classification for obesity. One thing about BMI is that BMI does not include your muscle mass. So it can be used as a marker, but also you can use other things as well, including body shape, which Dr. Swat talked about briefly. And what we're going to talk about today is the body shape is your natural distribution of your weight. And so there are many different body shapes as I have here. You can have an apple shape, pear shape, inverted triangle. So here showing your apple shape, your pear shape, inverted triangle, more of a ruler shape, and hourglass shape. And so typically an apple shape tends to carry more fat around the midsections here. And so that can be a problem. Also, now a lot of facilities are using body roundness, and that's something new that is coming into play in terms of determining obesity or classifying obesity. And so that's using your height, your waist circumference, and then pi. So what is considered a healthy plate? So when we think about a healthy plate, a few things come into mind. If we look at this plate, we're seeing a variety of foods, different colors, because the different colors are going to speak to the different nutrients in the different foods. We want to make sure that half of our plate is typically vegetables or fruit. And then we want to make sure we're having lean protein. So if you're looking here, you're seeing egg for protein. This is tuna, and then a variety of different vegetables, and then some starchy vegetables, which can kind of be used as carbohydrates. We want our plate to be balanced. We want it to have healthy carbohydrates, like I spoke about, in terms of brown rice, wheat bread, couscous, oatmeal, because we want our plate to make sure that we're having enough fiber. And so the fiber recommendations for women are at least 25 grams a day, and for men, at least 38 grams a day. And so to get that, you want to make sure that you're having your fruits and vegetables as well as your whole grains. Also here we have our protein and then healthy fats. And this is just showing different pictures of healthy plates. And so here, when we're talking about my plate for chronic kidney disease, this is an example of when a person has chronic kidney disease, of what your plate would look like, as well as it's going according to the guidelines of chronic kidney disease. So a couple of things to point out here is that sometimes some people feel like when they have chronic kidney disease that they're not able to have certain grains because maybe they're watching phosphorus. And so years ago, people were told that they couldn't have brown rice or they couldn't have oatmeal and things like that. And so it just depends, because the thing to keep in mind, and we'll talk about phosphorus, is that you have organic phosphorus and inorganic phosphorus. And when you have organic phosphorus, your body's only going to absorb 50%. And so this is just kind of showing you the different layouts of different food groups as it relates to chronic kidney disease. Okay. So when we talk about the renal dietary guidelines as it relates to the different stages. And so when you're in stages 1 to 4, you have different guidelines than if you are in stage 5 in dialysis. And so for some of the stages, depending on what stage that you're in, typically you want to limit protein. So 0.6 per kilogram of your body weight. So for example, if you weigh 150 pounds, that will only be 41 grams of protein. And that's to give the kidneys more, basically to give the kidneys a little bit of a rest. And so you would lower your protein. You also, depending on what your physician says, you may need to limit high potassium or high phosphorus foods, as well as high sodium foods. Now, if you're a person that is in stage 5 of kidney disease, and then you would need more protein if you're in dialysis. Okay. And then also, depending on what your physician, your labs, and what your physician says, you may have to have a fluid restriction. So when we talk about protein, we want to focus on high quality proteins. So things like your chicken, eggs, beef, fish, your lean proteins, as well as some of your supplements like Nepro, Novasource, and different protein bars. Your low protein foods would be things like your fruits, your vegetables, your grains, and your oil. Potassium is something that's very important to consider when you're in chronic kidney disease, because what's happening is that your kidneys are not always able to filter all the potassium foods. And so here, these are a list of some of the higher potassium foods like bananas and oranges, watermelon. And one thing to keep in mind is how much you're having of these particular foods. Because sometimes when you're looking at a list, it'll say, oh, you can have watermelon, but you can only have a half a cup. And realistically, no one's really getting a half a cup of watermelon. So you have to look at the serving sizes as well. When you have things like your white potatoes and your sweet potatoes, you want to limit them, but you can also soak them to remove some of the potassium. So that's something that could help as well. And then limiting things like tomatoes and avocados. Typically, when you're thinking of what's high and what's low in potassium, anything that's over 200 milligrams of potassium per serving is something considered to be high. Some of your low potassium foods that are okay to have: apples, applesauce, apple juice, grapes, your berries, zucchini, squash, cauliflower, and etc. So what happens if your potassium is too high? If your potassium is too high, then your kidneys can't function or take all of that potassium. And what can happen is, in the worst case scenario, it can lead to death, okay? And usually there's no symptoms. So you wanna make sure that you are monitoring your potassium, you're monitoring when you go to the doctor what your potassium levels are, as well as the foods that you're having. So when we talk about phosphorus, so like I said before, you have your organic and your inorganic phosphorus. And so for phosphorus, the high phosphorus foods are like beer, dark colas, Hawaiian punch, a lot of processed foods, because it's used as a preservative. In that case, when it's used as a preservative, like in terms of phosphoric acid, your body's going to absorb about 90% of that phosphorus. And so that's how, excuse me, that's how, if you're having the inorganic phosphorus, that is definitely going to raise your phosphorus levels. When we talk about the organic phosphorus, that's going to be high phosphorus foods such as your cheese, or even in some of your grains, they'll have phosphorus, but you're only going to absorb 50%, like I said before. And so some of your low phosphorus foods are like fruits, rice, pasta, corn cereal, and your flour tortillas, not the corn tortillas. This is a picture of some of the phosphorus additives that are in common foods. And that is, as you can see here in the picture, you'll have phosphoric acid, and you know that that's going to lead to inorganic phosphorus. One thing that is good is that sometimes in certain dark colas, like in root beer, you won't have phosphoric acid. Sometimes for the 365 colas, they don't have phosphoric acid. And so that's why it's really important to look at some of the additives in your common foods. And so why should we limit phosphorus? Because too much phosphorus can lead to calcium and phosphorus imbalance, and it can lead to calcification, as we heard about earlier in the other presentation. And so high phosphorus, what can happen is that it can deposit in your soft tissues and lead to calcification. It can lead to issues in your heart. It can go into soft tissues, your hands. Also, what can happen is it can be pulled from your bones and your teeth and weaken them. So plant-based diets and kidney disease, because everyone doesn't eat meat. Some people want to focus on plant-based diets, which are great. And so benefits of a plant-based diet, especially if you're in CKD stages 1 through 4, is that you want to limit protein in those stages. Like we said, 0.6 grams per kilogram. So you'll have a lower protein intake, lower blood pressure, decreased cholesterol, and better heart health when you have the plant-based diet. One thing to keep in mind when you are doing a plant-based diet is to keep in mind your sodium levels. Your sodium levels are important because sometimes with some of the vegan meats and some of the processed plant-based meats, you want to make sure that it doesn't have added sodium in it. And so these are some of the plant-based sources of protein listed here. And one thing to keep in mind is that foods such as lentils and dry beans, they can be higher in phosphorus, but you can still have them. So things to consider when you're following a plant-based diet and you're on dialysis is that it's totally fine, but you want to make sure you're getting your proper amount of protein. So you may need to have more supplements, like we talked about before, Nepro or Novasource Renal. Cade Farms also has a renal supplement as well. And you might need to increase your phosphorus binders if you're having more phosphorus in your plant-based foods, as well as, like I said before, looking at your sodium intake. This is a sample plant-based meal plan showing some warm quinoa topped with strawberries and 4 ounces of soy milk, mashed cauliflower with green beans, and stir-fried tofu with low potassium vegetables and rice. And I don't know how many people have tried the mashed cauliflower. I've personally tried to make it. It does come out really good. So I would urge you to think about it and try to make it. They have a lot of great recipes online. So for renal diet and diabetes, this is something that can be very challenging for people. And that's why I wanted to talk about it, because there are a lot of restrictions with the renal diet, and then there are restrictions with the diabetic diet. And so when you're dealing with both of them, some of the things to keep in mind is that you want to try to eat at your regular times. You want to avoid simple sugars, things like processed sugar, your added sugar. Keep in mind that all of us, we shouldn't have more than 10% of our calories coming from added sugar. You also want to, with CKD, you are at an increased risk of low blood sugar, depending on if you're on dialysis or not. And so you want to make sure that you're monitoring your blood sugar levels. And you also want to make sure that if you're with a kidney transplant and different medications, that you're monitoring your blood sugar, because obviously with certain medications that can raise up your blood sugar or lower it. And this is a sample diabetic renal meal plan. Having for breakfast 2 scrambled eggs with some chopped veggies, half a cup of blueberries, snack 12 grapes. And the reason why I put the number is because you also have to keep in mind, If you're on a fluid restriction, then fluids are also in your foods as well. And so you want to make sure that you're monitoring your fruit intake and vegetable intake because they do have water. Having 3 ounces of grilled chicken breast, coleslaw, water, and wheat toast. And this is showing you the snack and then also your dinner here. So sticking to your lean meats, having your fruits and vegetables, making sure that you following the proper serving size, and also having enough protein. So why is weight important? And that's what we're here to talk about. It's important because when you're at your proper weight, you have a better control of your blood sugar, you have decreased cholesterol and triglyceride levels, you have more increased energy, and then also weight is important when we're talking about qualifying for a kidney transplant, as you all have heard in your other presentations. So tips on how to manage obesity with CKD. One of the major things in managing obesity is to make sure you're not having extra calories or empty calories. As I said before, when we're thinking about our calorie intake, we want to make sure we don't have more than 10% of our calories coming from added sugars. And so when we're thinking about added sugars, we're thinking about when we're looking at a label, when it says you have your carbohydrates and then it says added sugars under that. And so we want to make sure that, let's say, for instance, if you're having 2,000 calories for the day, you don't want to go over 200 calories just coming from added sugars. And you want to make sure that you're practicing mindful eating. And mindful eating is eating slower, having a decreasing portion sizes. You want to make sure you're not eating in front of the TV or just eating just because you're bored, making sure that you're eating at the table and you're having proper portions. Sometimes you may need to have a smaller plate. That can help in terms of not overeating. Also increasing foods with fiber, because fiber helps you feel full longer. It helps you feel more satisfied. Doing daily physical activity. It's very important to be consistent. And so a lot of times when people are thinking about, oh, I want to lose weight or I want to manage my weight, it's like people will say, oh, okay, I have to work out for 45 minutes or an hour. And that's fine. But even if you do something 10 minutes a day, consistency is always great. And consistency typically leads to better results in the end. So it's better if you can do 10 minutes a day than to just do 45 minutes once a week or twice a week. So that's something to keep in mind. And it doesn't always need to go to the gym. Sometimes you can start taking the stairs at work. You can walk during your lunchtime. It's always good to have some type of movement after you have a meal, especially dinner. And then speaking with your physician regarding medications for weight loss, if that's something that you qualify. And for some people, bariatric surgery would be a great choice. These are my references, and that's it.
Thank you so much, Tisa, for giving us that fuel to go forward after we've heard from Dr. Kennedy and we've heard from Dr. Swan, we've heard Alexis's story. Now we have great information to move ahead with. So at this time, I'm looking at the time, we're even ahead of schedule. I mean, when you bring together the experts and the people who really know their stuff, it doesn't take all day to get it done. So at this point, we're going to bring everybody back and we'll have question and answers. I see that there are 2 questions in the Q&A, and I know there was one question that came up right away while Dr. Kennedy was talking, and I think Dr. Kennedy, at the time, you were talking about causes of kidney disease, and someone said, what about lupus? So maybe you could talk a little bit about the other about things that can cause kidney disease?
Sure. So that is a good question. I kind of mentioned the chronic illnesses that can cause kidney disease, diabetes, hypertension. There's also other things that are very intrinsic to the kidney, intrinsic kidney diseases that can cause kidney disease. Alexis had mentioned fibrillary glomerulonephritis. Someone asked about lupus. Lupus is an autoimmune disorder which can affect several organs in the body, including the kidney, right? Essentially kind of destroying the kidney and causing kidney damage. And we absolutely see lupus patients that have chronic kidney disease and go on to require dialysis and transplants. There's several kidney diseases, membranous nephropathy, one of the most common ones, membranoproliferative glomerulopathy, focal segmental glomerulosclerosis. So outside of just diabetes and high blood pressure causing kidney disease, there are other things and other intrinsic diseases. I do want to mention, since somebody brought it up, genetics. We have found, not really as of late, but I think there's just been a lot more talk around it, and there's a lot more research going around it with specific genetic abnormalities, such as the APOL genes that can be abnormal, especially in persons of color, in African Americans, which they are finding is increasing the likelihood of developing chronic kidney disease. So there's a lot of research going on right now. We've identified the genes, the abnormalities. There's research going on right now about medications that are, pointing to these genes, trying to resolve the problems so that we can lessen that impact, and particularly to the African American community with some of these intrinsic kidney diseases. So there are so many, I can't even go through all of them. I just wanted to mention those few, but that's a pretty good start. If you are diagnosed with any other type of intrinsic kidney disease, obviously find a kidney doctor ASAP so that you can get more information about that specific disease, because they all can be very different and there's very different ways to treat them.
Thank you. That was great. So here's another question. What are the different fats and how many are there? And what foods contain these fats? So I guess that's for Tisha.
So different fats, like you have your saturated fats and your unsaturated fats. And so your unsaturated fats are the fats that typically come from plant sources, and that's their fats that are liquid at room temperature. So in your unsaturated fats, you have like your mono unsaturated fats, which are your best fats, which would be like olive oil. And then you have your polyunsaturated fats, which would be still unsaturated fats and good fats, but maybe not as great as like monounsaturated fats. And so those can be fats from your avocados. You can have fats from your almonds, sunflower seeds, things like that. And so typically when we're talking about unsaturated fats coming from the plant sources, those fats are good because those fats are going to actually help to remove, it sounds crazy, but remove some of the fat in your body. And those are the good fats. And so they're going to help bring the fat out of your body through your bile. And so for your saturated fats, those are fats that are coming from like the fattier parts of your protein, like steak, or having like pork chop. And so those fats are going to be butter, cream cheese. Those fats are going to be solid at room temperature, and they're going to actually raise your cholesterol. They can also lead to heart disease. So I hope I answered the question. So when we talk about different fats, when we're talking about fats we should have more of, want to get more fats from things like avocados, your nuts, your seeds, your olive oils, and coconut has some saturated fat, but it's still good. One thing just to keep in mind, though, is that when we're talking about avocados are good, but you shouldn't have one avocado a day. So you want to do maybe like a fourth, okay? Because sometimes people will be like, avocados are good, I'm going to eat all the avocados, and then they're going to gain weight. because one avocado is about 350 calories. So we don't need to have one a day, but you can definitely have like a 4th slice. And a cool thing I saw on TikTok is you can put your avocado in some water, and it keeps it fresh longer. It's so interesting, like a cup with some water. Or what I'll do is I have like a sealer that I got on Amazon, but you just seal it and it just keeps kind of like the air out. So you can keep your avocado for the rest of the week. Okay.
Thank you. And thank you for keeping it real.
Oh.
Do not eat an avocado a day.
Yeah, they're good.
Okay. I do have another question here. Why are patients not told, or better yet, not recommended to see a nephrologist when they're in stage 1 and 2? I've seen many patients diagnosed with CKD at stage 3+, when labs have indicated unhealthy changes in previous labs. Is it true stages will not reverse, but become stable with diet, physical activity, and regular checkups?
I guess that's me. Okay.
I think so.
Okay, I don't want to make sure I don't miss the parts of the question. So I think the first part was asking about, do people with 1 and 2 need to see kidney doctors? Okay.
Right. Why are people not being referred
Yeah.
at stages 1 and 2?
So the real reason why people are not being referred at stages 1 and 2 is because there's a thought that primary care providers, because that is a very mild disease, can manage it. We tend to not see the some of those secondary effects of kidney disease, the issues with the bone, the issues with anemia, the potassium and the phosphorus start to get funny. We tend to not see those things until the kidney disease has progressed until at least stage 3. So that's probably a general basic reason why you don't see a lot of stage 1 and 2s being referred to nephrologists. Now, I will say, as a nephrologist, I see plenty of people with stage 1 and stage 2, and particularly if they have other huge risk factors like, your diabetics, your hypertensives, people that do have lupus or, these other diseases that we know are affecting the kidney. So it is not abnormal for a person in stage 1 or 2 to see a nephrologist, but you might have to press a little bit with your primary doctor if you recognize that you might fall into that category and you want to see someone, because it's not necessarily something that's standard of care, really. They do tend to wait until it's, high stage 3.
Okay, and then the other part of the question is it true stages will not reverse, but become stable with diet, physical activity, and regular checkups?
Okay, so I will answer that in two separate, two answers, really. Will stages reverse? I have very rarely seen chronic kidney disease reverse. Again, it is called chronic for a reason. Things that are chronic, we need them to get under control or they tend to progress. I have seen patients maybe who had very, very poorly controlled diabetes or very, very poorly controlled high blood pressure. And once we're able to get those disease processes under control, you might see a little bit of improvement in their kidney function, but we're not talking about leaps and bounds, okay? So, if you're at stage 3, is it likely that you're going to go back to stage 1? Very, very unlikely. All right. Definitely depending on what the cause is. I am not God. I will never say never, but that's something that it doesn't typically happen. That's not what we would expect to see. Okay. And then the other part of the question, did I miss anything? Stabilization.
Yes,
Yes. We definitely do see with improvements in your diet, maintaining that healthy weight, keeping your blood pressure, keeping your diabetes under control, managing proteinuria, we definitely can see stabilization of chronic kidney disease. Those medicines that I had mentioned when I was talking, the SGLT2s, that is what they have been found to do, which is why we're now calling them a treatment for chronic kidney disease. This is relatively new. We really weren't able to treat it before, but we are saying that with the help of these medications, we see that stabilization. So yes, it is possible to stabilize your chronic kidney disease if we can get all those things in order. Now, I have to make the caveat, getting everything in order may not automatically mean your disease is going to stabilize. If it doesn't do that, we are at least hoping that it's going to slow down that progression.
Okay, thank you. Next one, what are some exercises you'd recommend for someone with limited mobility due to other health issues? Alexis, you want to answer that?
Um, like I say, walking is the best thing that you can do, but there's other things that you can do. Even if you can't get around, I have seen where people who may even be using a walker to get around, to sit in a chair and stand up on their walker and then sit back down. That's a movement if they're able to do it. I've seen people use, if they don't have weights, they take cans of, soup and just, sit in place and just move around and do certain things. So it's all about just keeping the body moving as much as you can. And are you going to be able to go and do a CrossFit class? Probably not. Um, I've done boxing, I've done weightlifting. I really enjoy weightlifting, but because, I have issues with my joints sometimes and sometimes with my back, it will keep me from being able to do it as much as I like. But I just try to make sure that I keep moving. I do a lot of lifting. And like I said, I just do a lot of walking. Walking is probably going to be the best thing if you have limited mobility. You can walk around, your house if you can. So, thing is just keep moving. You don't have to be a member of a gym. You don't have to have a trainer, anything like that. Those things are great. I love working out with trainers, and things like that. But if you're not able to do it, it's just moving the best way that you can move, what works for you, because what works for one may not work for the other.
I wanted to add water aerobics or water
Mhm.
exercises are very beneficial for people with weight bearing limitations. So whether it's in the joints in the arms or your joints in your legs, getting in water and moving around is very beneficial. And I don't know all the centers, but even some of the YMCA's will often have discounted rates where you can get in the pool and do water aerobics with a group, and their instructors there. But I wanted to echo what Alexis said about walking. Anything that you're able to do where you can increase your heart rate a little bit, and do it safely and consistently, I think is beneficial. Even holding on to a rail and walking up a few steps back and forth, sitting in a chair and doing some exercises where you're lifting your ankles and things. There are a lot of things online you can look up too, and videos of people who are limited but who are working to be more active. And sometimes even depending on what your limitation is, if you need to meet with a physical therapist, that's a really safe way to maybe get some good exercises as well that you can do at home with things like Alexis mentioned, cans or bags of beans. You can get pretty creative, but you want to just make sure you're being safe, especially if mobility is an issue.
I just wanted to add, there's some really cool YouTube videos where there's a woman who it's walking 5 miles, but you're just walking like one step up, one step back, one step to the side. And so I did it just to see, like, is this really 5 miles? On my Apple Watch, it was really 5 miles. And you're just doing like one, two step. You're kind of like stepping in place. So it's very small steps. And then also the Croc Center is a great place for like water aerobics. They have a lot of classes and they're pretty affordable too.
Mhm.
Awesome. Next question is, would you suggest a good reference book on kidney diet?
Yes, they have a lot of them out there. So I need to get my list together. Because I like the cookbooks. There are a couple of people who have cookbooks where they kind of went vegetarian and they kind of froze their stage in one place. And so there are a lot of books, but I will have to kind of get my list together and give it to Monica.
Okay, that'd be great. If you get a list together, then we
Yeah.
will definitely post it.
Okay, sure.
Awesome. Another question uh, about support groups from the South Side. Okay, yeah. So here's the question. Please provide information about active support groups on the South Side for teens and adults. And thank you for an excellent seminar. I am not aware of any active support groups for kidney patients. I don't know if the panel is.
No.
Some of our patients will share that they've kind of created their own, communities, whether it's patients that they've met at dialysis or in another group within their hospital system. But that is a great point, and I think something that would be beneficial to partner with what Dr. Kennedy said about having a really good doctor who knows you well and who you trust and who will be able to pick up on changes and make sure that the diet you're reading about is making good changes or is healthy for you. I think just as important as that is having a community where you can talk and help each other and encourage each other. So it's something we're working on, but unfortunately, I don't have a specific answer for you either, but hopefully I will soon.
So here's a suggestion. You can come along to the NKFI and become a volunteer. And we become like a little family.
Yeah.
And we talk about kidney disease all day and all night. So
Mhm.
it's better than a support group, I'd say. So just reach out to me and get involved. And okay, one of my teammates is prompting me that our Take Charge program is a great way to have a virtual group of supporters. So we do have a program that lasts 8 weeks. It's 2 hours a week. And it's a small group setting, about 15 people with 2 moderators. And it's really a great program. And it does give you everything that happens in that group stays in that group. And so it does give you, we talk about how to manage chronic diseases. And the last 2 weeks are focused on kidney disease, but for 6 weeks, we talk in general and give tools about how to manage chronic disease. So at the end of it, you will have spent 8 weeks with 10 to 15 people who have similar issues as yourself, and you may have a community right there. So thank you for that prompt about about Take Charge. And we also have Kidney Connections, which is what used to be Living with Kidney Disease and Transplantation. That's another patient program that comes up. We have the opportunity to network together at the end of the inpatient program, in-person program, I'll say. We do have a couple of virtual programs that go along with it, but then we have an in-person program with breakout sessions and lunch and opportunity to network with other patients. And here's a question for Tisa. What is the name of the video for exercise for steps that you mentioned?
Let me, I'll put it in the chat.
Okay,
Mhm.
okay. Here's another question. Are there any physical warning signs of beginning stage kidney function decline?
I can answer that. So no is the simple answer. A lot of times the symptoms of kidney disease really don't start to come until it's quite advanced. So patients that have stage 2, stage 3, there really are very few symptoms. And even as people advance, the symptoms from chronic kidney disease are often attributed to something else. So, fatigue, loss of appetite. You might start losing a little weight because your appetite's not that good. You know, big things that people usually don't notice. There's usually not like a change in your urine output. People always think like, oh, if my kidneys aren't working, then I'm not peeing. But that's not necessarily the case. A lot of times kidney patients are still, even dialysis patients are still making urine. They still go pee. But that urine is just not, it's poor quality. So it's not urine that's full of all the substances we're trying to get out. It's just water. So there are no really big signs symptoms for chronic kidney disease until it's quite advanced. And typically by then we are aware, but the soft signs are, fatigue, poor appetite, nausea. A lot of times, many people have that, and, we don't even think that it's chronic kidney disease.
Okay. Well, I think that completes our questions. We have had a very engaged audience, and we have had some amazing presentations here this afternoon. I want to make sure that everybody knows we have recorded this, and we will share it. We will send out an email tomorrow to those who attended. I think maybe even those who registered and missed it. And then we will also have it posted on our website so people can access it. And then if Tisa gives me a list, we'll get that posted on our website as well. So there were lots of thank yous and lots of people saying what great presentations these were in the chat. So thank you all so much. I am so delighted that you would take time out of your busy schedule during this short month of February to have this discussion with us. So everybody have a great evening. Oh, wait, I got to bring it back to Jackie. I'm sorry. I'm not closing it out. I'm bringing Jackie back. She's not pictured, so I was confused here. So we're going to bring Jackie back to do closing remarks, and that'll be it.
I put the YouTube in the chat.
Okay, yep, I see it. If Jackie turns her camera on, then they can highlight her. Here we go.
Hello. All right then.
Hey.
All right. First, I had to rejoin as a panelist. What I really want to do, this has been a phenomenal webinar. The information is outstanding to the point that, and all of our speakers, thank you so much. And it's just such, a source of pride, a source of information and moving forward with the information that our kidney communities and caregivers can benefit from. So what I did is for each of our speakers, I just had I was notes, where's my, okay. I had a takeaway. So for example, starting with Alexis as our patient, as she offered, listen to your provider, stick with your health regimen. Then moving to Dr. Kennedy, know your numbers, including your A1C, EGFR, ACR, all the wonderful indicators that she referenced and that we should know our numbers. Moving to Dr. Swa, and this in her statement, her profound statement that recovery is just as important as the operation. Then moving forward to TISA, and in addition to the avocado, you will always be known, TISA, for the don't eat an avocado a day. In addition to that, and that we can step and go 5 miles, and all the diet examples and meal prep examples that were provided. And of course, ending with our phenomenal moderator, Monica Fox. So thank you. And of course, I also want to thank our sponsors, again, Blue Cross Blue Shield of Illinois, our presenting sponsor, and also recognize our other sponsors, Fresenius Kidney Care and UI Health. And in terms of closing this out, and to remind people, oh, but I have it right here. The journey continues. Our podcast that we have that really features key stories that change lives, stories that, and as well as information that is provided. So thank you again for joining us. And to all of you, as Monica indicated, that took the time. Thank you so much.
And I have to just put a shameless plug in. for two things.
Okay.
One is World Kidney Day, which is March 13th, which will be at St. Augustine College in Chicago. And the second thing, which is the Walk for Kidneys, which is June 1st, and teams are open now. So let's get started because I'm competitive, y'all. And I like all the perks. I like all the little giveaways. I know I get everything anyway, but I'm gonna earn my giveaways as I do every year and earn as much money as I can. So let's get going now.
What a
All
way
right.
to end. Thank you all. And that's why we can't wait to see you for Team Kidney. Thank you for being a member of Team Kidney. All right. You guys take care. Have a great evening.
Yes.
Thank you. Have a good
Have
night.
a great night, everybody. Thank you.
Thank you.
Bye-bye. Thank you.